We're very fortunate to have Dr. Barry Friedlander as our guest speaker. I'll tell you just a little bit about Dr. Friedlander and then introduce the topic. He received his undergraduate and MD degrees at the University of Michigan. He followed a residency in Michigan by doing a fellowship at Mass General Hospital in musculoskeletal oncology. It's fair to say that I think many of us consider him one of the founding fathers of that specialty. In 1976, after serving 2 years in the U.S. Navy, he joined the faculty at Yale. And from 1986 to 2016, he served as the first chair of the Department of Orthopaedics and Rehabilitation, as well as the chief of that service at Yale New Haven Hospital. He's been president of many of our national committees, including the American Association of Tissue Banks, the American Council of Transplantation, the ORS, the Academic Orthopedic Society, Association of Bone and Joint Surgeons, the AOA, and has served in many important roles for our academy. So I'm very grateful that he is virtually joining us today. And Dr. Pirkle, who is assisting him, I think may have given him the most difficult topic I've perhaps ever seen for Grand Rounds. And it's Caring Beyond the Bones, the intersection of medical humanities and orthopedic surgery, a challenging topic, but something I'm really looking forward to hearing about. And I think we'll all appreciate Dr. Friedlander's and Dr. Pirkle's perspectives. So thank you.
Thanks so much for having me. Let me see if I can get my screen share working here. All right, thank you so much again. My name is Sean Pirkle, and I'm excited to talk a little bit today about the intersection of medical humanities and orthopedic surgery. And special thanks to Dr. Friedlander for being here with us. So I think it's best to start with a few clarifying terms that we all might be a little bit less familiar with. The humanities more generally are defined as a group of disciplines that study expression to help us understand what it means to be human. They can include the study of history, literature, philosophy, religion, art, music, theater, and more. The medical humanities aims to answer questions about health and illness, including how social, cultural, and historical factors can impact a person's experience of illness or access to medical care. Medical humanities can also examine the ethics related to clinical care, public health, and scientific research. There have been many physicians throughout history who have been advocates of the humanities, whether in name or through action. In Greece, figures like Hippocrates emphasized the importance of understanding the patient's experience. He's known as the father of medicine largely because of his contributions to this idea that disease was spontaneous instead of attributed to supernatural causes, such as divine punishment or demonic possession. But his contributions to medicine also focused on observation and understanding the patient as a whole. And its emphasis on medical ethics led him to being the namesake for the Hippocratic Oath, which continues to guide medical practice today. Similarly, in ancient China and India, medical traditions also integrated philosophical and ethical perspectives. During the medieval period and into the Renaissance, medicine was closely tied to religion. Maimonides and other medieval physicians often combined medical practice with theological inquiry, harmonizing faith and reason. This holistic approach emphasized the connection between the mind, the body, and the soul. The Enlightenment brought significant changes in medicine as well, with an increased emphasis on the scientific method. And leading into the 19th century, the formalization of medical schools increasingly focused on scientific training. However, this shift often came at the expense of the humanistic aspects of medicine. Despite this trend, some medical educators and practitioners continued to advocate for a more integrated approach. Figures like William Osler in the 19th century advocated for the importance of the humanities and medical education, emphasizing the role of the physician as a compassionate healer and scholar. The formal establishment of the medical humanities as a field began in the 1970s, and programs were developed at medical schools, often incorporating literature, philosophy, history, and the arts. These programs aim to foster empathy, reflection, and a deeper understanding of the patient experience. Over time, it has slowly become a global movement, with increasing recognition of the importance of understanding the cultural, social, and emotional dimensions of health. The field now includes diverse disciplines like narrative medicine, bioethics, and medical anthropology, and includes works from popular figures such as Atul Gawande, Oliver Sacks, Raphael Campo, and Jerome Groopman. So why does this matter, and why are we talking about this today? This is a quote from one of my medical school mentors when I was about to start my clinical rotations. He told me, obviously, try to get honors in every MS3 rotation. But if you get a high pass in your psychiatry rotation, ortho programs may see that as a positive. A bit of tongue-in-cheek here, and likewise in the memes pictured on the slide. But in every joke, there's a little, or perhaps a lot of truth. And what I'm trying to get at is that in orthopedics, we are extremely evidence-based, arguably more so than other surgical specialties. In my opinion, this is a good thing. Evidence-based medicine has improved outcomes for our patients. It's the foundation for research in our field, and we do this with such fervor that we can publish articles like this without even batting an eye. At the same time, we are stereotypically inhumane. The bone is broken, we must fix it. Any issue or complexity is admitted to medicine. I think it's an accurate characterization of evidence-based medicine and narrative medicine as opposites, as yin and yang, but I want to argue that finding an appropriate balance in our practices can make us better caretakers and make us better healers. This is a study from 2018 in the Journal of Surgical Education on empathy in surgical training. The authors report that a decline in empathy exists that begins during the clinical years of medical school, which continues throughout residency training. I would agree that practicing in a humanistic manner can be challenging in modern medicine. Financial and time pressures, the use of technology in place of personal interaction, and a decreased emphasis on the humanities and physician education are just some of the factors that might contribute to a sense of dehumanization. Empathy demonstrates the physician's understanding of and concern about the patient's thoughts and feelings. In this study, patient-rated surgeon empathy was the strongest driver of patient satisfaction. And while we may view ourselves as empathetic listeners and effective communicators, in this study by Tung et al., 75% of orthopedic surgeons felt that they communicated satisfactorily with their patients, but only 21% of orthopedic patients reported having adequate communication with their caretakers. This has led orthopedics to being described by patients and in the conclusion of the AAOS as high-tech and low-touch. Numerous studies have shown that increased provider empathy improves the health of the patients that we care for. Why else might this matter? If appealing to improved patient experience and better outcomes does not do the trick, poor levels of empathy and communication are one of the leading causes of medical litigation. In this study, the doctor-patient interaction was the second leading cause of lawsuits, behind only the presence of a medical complication. Here's another study which emphasizes this point. The authors go on to say that despite the occurrence of harm to the patient, the proper way in which physicians have related to their patients contributed to the patient's decision to not complain about a medical act. I could go on all day with studies that reinforce this point. The Annals of Surgery concluded that 34% of malpractice complaints were related to poor communication. Historically, the most significant way in which physicians have engaged in the humanities has been through writing and narrative medicine. It seems only proper that a physician write an article about advances in our understanding of disease or give a layman's interpretation of the latest change in the US healthcare system. But these pieces only represent a fraction of the works from a larger community of physicians for whom caregiving runs in lockstep with writing. Perry Klass is an American pediatrician and writer. She's also the National Medical Director for Reach Out and Read, a literary organization which works through doctors and nurses to promote parents reading aloud to their children. She writes because it has shaped her as an observer and a storyteller, and therefore certainly affected her as a clinician. Writing has been a path to imagining and understanding lives that she has now lived. Dr. Danielle Ofri is a primary care internist at Bellevue Hospital, clinical professor of medicine at NYU, and editor-in-chief of the Bellevue Literary Review. She shares that we work fast, we talk fast, we eat fast, and we walk fast, often at the same time. Writing is an almost sacred experience because when you think on the page, you are forced to slow down and engage in discovery. In this editorial by our very own Dr. Leopold and Core, he shares that the concept of narrative medicine holds that by becoming more insightful consumers of the stories we see and hear, through the written word, the stage, visual art, or other sources, we become more empathetic listeners to the stories our patients tell, and by extension, more reflective, trustworthy, and effective practitioners of our profession. This is an editorial by Dr. Schaefer out of Johns Hopkins, published in JBJS. He co-runs the site Closler. The site is a melding of the words closer to Osler, a tribute to Dr. William Osler, who is most remembered for revolutionizing formal medical education by teaching at the bedside. Dr. Schaefer argues that one way to be a humanistic orthopedic surgeon is to address the most common procedure that we perform, one that we might do 100,000 times during our career, the patient interview. He highlights an opportunity for what he calls the small talk before the big talk, an attempt to connect with a patient with something outside of medicine, if only for a few seconds, before getting back to the history of presenting illness. It has been shown that we interrupt patients at an average of 18 seconds after the patient starts talking, which honestly seems like an overestimation to me. This behavior can be frustrating to the patient, who may feel that their story is not being heard and that the orthopedic surgeon is uncaring. Dr. Schaefer encourages us to learn about patients and briefly document these details in the record for recollection later. A 37-year-old construction worker, an Army veteran, or likes to play guitar, recalling this information can be an effective tool for relationship building. So why do I write? And who took this stock photo of me without my permission? I suppose it could be broken down into two limbs. Of course, nothing in life is altruistic, and there is some secondary gain. Writing for me is an opportunity for self-reflection. This is a hard job, and there are times when we will see things that no person should have to see, or alternatively, behave in a way which is not productive. Writing helps me process these emotions and better understand another's perspective. I write to get better, to identify areas for self-improvement, which will help me become a better physician. And if I happen to publish the piece, there is some element of self-promotion. But a lot of my motivation to write is to have a voice in something bigger and outside of my small circles. The pen is mightier than the sword, and by writing, I've given myself an opportunity to raise awareness for issues that are important to me, to propose solutions in a public forum, and to advocate for change. This is an article I wrote as a junior resident. It's a self-reflection about the insecurities I was experiencing and to some degree continue to experience on a daily basis. When we talk openly about imposter syndrome, we can destigmatize feelings of self-doubt, and if nothing else, promote self-compassion. I've used writing to highlight areas for self-improvement and to help me process feelings of anger, frustration, and guilt. I wrote this article in the middle of R2 year on the walk home from a difficult call shift, and I've read and reread it after many difficult call shifts as a way to stay centered and more calm. I've used writing to find gratitude, to reflect on my journey into medicine and the path to becoming an orthopedic surgery resident. This article is a reminder that this job is a privilege, no matter how dark it can be at times. This is an article I wrote with Dr. Friedlaender, published in JBJS through their What's Important series, which uses narrative medicine to initiate a dialogue about medical mistakes and to provide advice to others going through similar experiences, which no doubt will be all of us residents and junior attendings. Dr. Friedlaender provides the following reflection on a young patient in his practice who sustained a near full amputation of his arm after being struck by a train. After many rounds of serial debridements, he reflects that he came to realize there are times when it's a mistake to proceed with a strategy when the likelihood of its success is nearly zero, or certainly when that strategy is beyond his resources and talents. Dr. Antonia Chen shared a challenging case of hers with unexpected bone loss and a young primary total hip. She shared that there are times when she doesn't have all the answers, that she must swallow her pride and ask for help, and that asking for help was probably the most important thing for the patient outcome. Dr. Julie Samora shared a difficult case in which a young patient had a poor outcome after a routine elective procedure. She discusses second victim syndrome and how that she wished she had recognized her symptoms while she was struggling with them, so she could have sought counseling, though she ultimately found support from her husband, colleagues, and family. We can use writing to advocate for continued progress and to attempt to promote intergenerational understanding and conversation in a profession in the midst of a significant culture shift. In this paper from earlier this year, I discuss a podcast from the New England Journal arguing that a perceived fad for resident work-life balance is dangerous for patient safety. I countered that by all historical measures, efforts at ongoing change are seeking to address high rates of depression, burnout, suicide, and substance abuse in our profession. And for all the differences that exist between the old guard and the new guard of medicine, there's always room for discussion of difficult topics, and writing has given me a seat at the table to provide solutions to make the practice of medicine better and more enjoyable. Writing has been an avenue for me to push for improvements in orthopedics and to make the process of recruiting new trainees more equitable as well. It has been a way for me to challenge myself and my colleagues to become more compassionate physicians. I'm fully aware that the time that we spend with patients in the ED, in the clinic, and in the operating room is a finite resource, and we have to be able to triage. This often means that being a compassionate physician and a competent orthopedic surgeon are different and competing goals. Not every day is like that, though, and most patient encounters have the opportunity to connect with others. I would argue that being a one-dimensional surgeon is worse for patient care. And one important way that we can stretch our imaginations and better empathize with patients is to reflect on our own choices and to have a willingness to see another's perspective through engaging in the medical humanities. And with that, I'll turn it over to Dr. Friedlaender.
Boy, that was fabulous. Thank you very much. Let me make this happen. We all okay? Good. Well, again, thank you. I apologize in advance for stuffing too much in the next few minutes. Sean has set this right here through this a bit more effectively. Also, I must tell you how flattered I am to be at the University of Washington. Good Friends is a program that is extraordinarily well entrenched in our history, in our teaching and clinical practice today, and well into the future. Have to shout out Rick Mattson, good friend, along with Seth Leopold, Lisa Tatesman, Paul Manor, and I could use the rest of my 20 minutes to go down the list of your extraordinary faculty. But they have pleased I be here and to talk about this subject. My disclosures are of a completely non-compensated nature and mostly our relationships, including Seth Leopold and my wife. And I'll not spend any more time on that. But what I hope to do over the next 20 minutes or so is convince you that art is valuable, not as a substitute for science, but as a complement to the science we're much more familiar with. And I hope that in the next few minutes to really demonstrate that this is true in terms of enhancing our skills of communication and observation. And observation is where I'm going to concentrate, but it is also a interesting and I would say fairly reliable source of history of medicine, and certainly in our quest to be more empathetic and understanding about our patient care. John's already talked a bit about the hugely important topics of communication skills, and I only bring it up to point out that skills are things we can learn. We can learn how to communicate better, and I would also forward the notion we can also learn to see better. If we can't, in fact, see it, smell it, taste it, touch it, we can't use it in our clinical practice, and that's a huge disadvantage to ourselves as well as to our patients. And my personal epiphany was when my father's barber noticed that he was jaundiced, and that led to his diagnosis of pancreatic cancer. As unfortunate as it was still important to know. My wife, Linda, had a similar epiphany, if you will. She was visiting a friend in the hospital, Her friend was anxious, disheveled, clearly uncomfortable when the team walked into the room, asked how she was doing, as we always like to. The patient said, "I'm fine," and they walked out without ever leaving their hand from the handle of the door. And my wife realized they had completely missed all of the clues that would have been very helpful to them, and developed this course where she sat Yale freshman medical students in front of a narrative painting, as you can see in the background, asked them to put aside their initial reactions about what's going on, but inventory in a painstakingly long period of time, 15 minutes, everything they could see before putting it together and coming up with conclusions. If she were here or I was there with you, I would be tempted to put this mid 1800s painting by Henry Wallace entitled Chatterton. In fact, it has a longer title, and go through an exercise of inventorying all the things you see in this painting before you come to a conclusion. I hope some of you are already coming to conclusions and kind of fighting that instinct to come up with an answer to what's going on. But rather than call on you, which is just inconvenient despite the technology, my wife would ask you what you see. You would jump to some conclusions, and she would quickly tell you not to do that. Yes, it is an individual lying on a bed, and yes, there are some shredded papers next to the head and arm falling off the bed, and yes, there is a little vial on the floor near his hand of some unknown substance or some reason that it might be important to this scene. But what you really will come to at some point is the need to make a decision. Is this individual on the bed sleeping? Is this individual on the bed drunk or drugged? Is this individual on the table, on the bed, dead for some reason? And in inventorying everything, there is a way to come to a logical conclusion. But there is also an advantage to knowing the story behind this, and I will share it. This is a young poet. The poet has committed suicide from cyanide that was involved in that little bottle on the floor after shredding his poetry papers, having been accused of plagiarism, which I think he would have disagreed with, but this was his reaction. And in the romantic sense, there are some other clues here, the open window for his escaping soul and things like that really go far beyond medicine, but is part of the language. We can use these same observation skills, whether we're looking at skin pigmentation patterns, cafe au lait spots, the blue sclera of osteogenesis imperfecta, skin folds and developmental hip dysplasia, or even looking at portraits of Richard III, who was supposed to be an evil, deformed king, died in his 20s, and his skeleton was recently exhumed in a parking lot in England that told that not the way Shakespeare presented him 100 years later, and having never known him, but he had scoliosis, but he wasn't a hunchback and evil because of a twisted skeleton. What I'd like to do next, and thank you, Seth Leopold, is go through some of the opportunities my wife and I had to share in clinical orthopedics and related research, some adventures we took over about 15 years. there are some early observers to uh, to health, to medicine, to anatomy, and no better place to start than with Vesalius. And this is a picture of his anatomical drawings from around 1543. And you can see that he was a very, very keen observer, one of the first to put his anatomical knowledge from dissection in visual form. And if you were to stare at this, and I'm not going to let you do that for very long because I have to move ahead, but these images, diagrams are readily available. You'll see they're incredibly accurate. It went on the next century to a more widespread use of anatomic dissection, sometimes surreptitiously, sometimes not, as we see here, both by Rembrandt and Vandermeer, who are shown in the midst of anatomy lessons. This anatomy quickly got used by artists, and George Stubbs here in the 18th century, depicting animals as he was fond of doing, it is very apparent that he understood the musculature, the anatomy beneath the skin, as many artists were doing by this time. This is another example of anatomic knowledge. These are sculptings of two of our former residents by my mentor, Dr. Wayne Southwick, and they will live forever in bronze on the grounds of our medical center. But again, a very, very keen observer, and he took full advantage of his knowledge and his skills to put these before us. There's a lot of history captured in art as well, and that's extremely helpful. And I'm going to tell you a couple of stories very briefly, this being one of my all-time favorites, and it is from the early 1500s. It's a scene of Saints Cosmas and Damian, the patron saints of medicine, in the 4th century AD, performing one of their 3 prerequisite miracles, where they have already transplanted the healthy limb of a Moor donor, and we could talk about that in more detail, for the diseased limb that's on the floor. And while we are still doing some of that stuff today, Howard and I, there are some other things that are also prescient and still in play today. Orthopedic surgeons clearly are identified by their halos. You can see the angelic help in the operating room, the indirect and poor lighting, and as always, the anesthesiologist is out of the room. Here we see Thomas Aiken's rendition of the Gross Clinic, a compendium of surgical care, this painted in 1875 for the first centennial of the United States. And Thomas Aikens is actually here in the background in the stairwell. And we see Dr. Gross in all his glory, standing there in his street clothes, as they all did, in front of the horrified mother of the patient with the bloody scalpel and no regard whatsoever for germs. Here, his assistants are decompressing an osteomyelitis of the thigh. It pays no attention whatsoever to the fact that 25 years before this scene, Louis Pasteur had already developed and presented proof of the germ theory, and Joseph Lister had already demonstrated that there were ways to create sterility, the use of carbolic acid, and eventually Listerine. All well known on the other side of the Atlantic, and completely ignored by some egotistical, albeit talented surgeons here in the U.S. And because of this, when President James Garfield was shot in the back in 1881, he died not of the bullet, even though it got stuck in the spine. He died of the myriad of dirty fingers probing his wound, trying to find the bullet, thinking that that was the key to success. And he succumbed about 4 to 6 weeks later of the infection that resulted from this and from ignoring the principles that were already well described across the Atlantic. So you can ascribe Garfield's death in large measure to folks like Dr. Gross indirectly. His colleague, Dr. Agnew, 10 years later, after the death of Garfield, still he put on a clean robe, but did nothing beyond that to respect bacteriology.
Yes.
We then are treated to a variety of paintings that emphasize the empathetic and high value the public patients placed upon the health profession. And here, Luke Viles, the doctor, is emblematic of that. Here, all the good doctor could do was look, watch, wait, had very little to offer other than his empathy. But for that, and despite the lack of curative approaches, healthcare professionals were held in very high regard and well-deserved. Even artists, and here Francisco Goya is paying tribute to his doctor, Goya in the foreground, and Dr. Arrieta has his back, literally and figuratively. Another fascinating story in the art world is that of Frida Kahlo, and here we see evidence of the beginning of her story when she was injured in a motor vehicle accident as a teenager returning from college where she was pre-med. And parts of her injury included a fracture of her lumbar spine, kept her in bed for a year, and it was in bed with her father's art supplies that she learned how to paint. And she used that skill to share with us some of her most serious illnesses. This is her actual x-ray, which is published, so I don't think I'm violating her personal history, showing her spine fusion, which she depicts here in her painting of 1946. Here she is, and her palette is her heart, painting a tribute to one of her primary doctors, Dr. Farrell, who was responsible for a great deal of her care and the target of her affection because of that. Sean already talked about narrative medicine, the ability to relate to patients on a much more personal level, something that Rita Sharon has written about for more than 20 years, and something that we should aspire to. But there are clearly is evidence as we learn to look at our patients of the emotional impact of their clinical state. Here, Vincent van Gogh, this souring old gentleman, clearly is emotionally distraught, and that's an important part of his persona and his illness. Edvard Munch probably found one of the most impressive ways to connote emotion in his paintings. Hear the scream. This is one of 4 versions that he did uh, over the years, and is haunting in its intensity. I want to, and I'm getting close to the end here, show you a photograph, another piece of art, because I think it's a call to action on our part. Here, Rente Taylor, um, a slave in South Carolina on a cotton plantation, was photographed at the request of a Harvard professor, Dr. Louis Agassiz, and you just have to look at this to understand there's an important story and much to learn by really inventorying this face, this body, this context. The professor used this photograph and those of his family and others to promote white supremacy, to indicate what he thought were flaws of people of color at this time. His family, his descendants have, there's a great movie about this, have asked for custody of these photographs from Harvard and were denied. But at some point in time, I hope you look at these photographs more carefully and come to your own conclusions about the dignity of this gentleman and how it's being violated by the context. I'm going to try to do this myself and share it with you when I get a chance. I'm not going to spend more time defining narrative medicine. Other people have done this very well, including Sean's introduction, including authors, including this book, which was literally and figuratively breathtaking, When Breath Becomes Air. And I hope that in this rather quick overview, I have been able to convince you that art is of importance and beyond that of value in a number of ways as we approach the care of our patients. And I contend that paying more attention to our observational and communication skills, our understanding of the history of where we've been and where we're going, and the use of empathy will improve our clinical practice and our patients. I think it makes a difference, and I wish it on you. As a closing gesture of observation, look at this. You've seen it 3 or 4 times already, and look at it more carefully. Some of you will already have noticed this is not a picture of a bird. This is a picture of a person masquerading as a bird. So things are not always what they seem. And with that, again, my gratitude for your attention, and hope this stimulates some discussion in your own mind with yourself and with your colleagues, and take from it what you will. Thanks, guys.
Yeah, thank you very much. That was wonderful, and I was wondering how you were going to pull this off, and now I get it, and it was really a great talk, and also thank you, Sean. We have quite a bit of time for comments or questions. You can just write something in the chat box. You can text me, or you can just, I see Dr. Henley raised his virtual hand. You can do that, or just chime in, Brad.
Yeah, hi, Gary. Brad Henley. Sorry, I have a cold. Nice to see you. You've done an excellent review of classical art and medicine. I'm wondering if you could spend a few minutes trying to prognosticate into the future of what you think the intersection between orthopedics and humanities and art will be, especially with the contributions of the computers and AI in art. Because well, I'll leave it at that.
Well, first of all, it's nice to hear from you, Brad, and sorry I can't give you a hug. Um, thank you for that question. I think I would like to reemphasize that I'm not trying to convince you that art is a substitute or humanism is a substitute for science, but they're colleagues, they're partners, and that we have to find ways to bring these aspects of our character together as we treat patients. And there used to be a time when I looked at my clinic list just like a lot of you do, and realized I was already 45 minutes behind, and I was destined to get a barrage of not so welcome comments as I walked in the room late and uh, portrayed some disrespect, if you will, for the patient in their minds. And then I took this communication skills program from the academy, and 20 something years ago, in fact, I was on the committee for the academy with John Tong and um, Jim Herndon, as we tried to conceptualize this and how to spend the $1 million that the academy was going to put into teaching communication skills. And you know, I got to tell you, it turned things around for me. So instead of walking into the room defensive and saying, you know, my time's valuable too, and why are you grabbing? I'm here to help. I learned to walk in the room and say, hi, I'm Gary Friedlander. I'm sorry I'm late. And I do that even when I'm not late. And it just allows me to interact with people as individuals and not as items and patients, and have a conversation. And I think that our future, as we use the humanities, if you will, to put some humanism in our attitude, our conversation, slow down, look, and put things together, that I'm enjoying, and I think you're going to enjoy healthcare a lot better in this time of great stress, you know, from so many different directions, both economically and electronically, if you will. I was in, I'm sorry to be so long-winded about this, but I was a patient yesterday at a healthcare checkup, and I pointed to there was a cell phone on the counter as my doctor was about to leave, and I didn't want him to forget his phone. And I said, "Is that yours?" And he said, "Yeah." And the phone was recording our conversation with an AI app that was then going to write his note. And I asked him how he liked it, and he said he actually doesn't. It saves him time, but unless he creates a dialogue in a certain construct, the note really isn't as valuable as he would like. So I think we have to learn to be human. We have to learn to take advantage of technology in the future, and we have to remember to do it in a humane, humanistic way. And to blend all of that together is our challenge. Far too long an answer, and probably didn't really get to the core of what you want. But I'm optimistic about the future.
Do we have any other questions? I would follow up on a comment on what Dr. Friedlander said. As you and Sean were speaking, one of the things that I was thinking is, you know, clinic can be tough. As you said, you look at your schedule for the day and you're like, wow, how am I going to get through that? But if at the end of a clinic, I feel that I've had some just nice conversations, narrative conversations with my patients, if we've got to tell each other a couple of jokes or had a little bit of a lighthearted conversation, at the end of that day, from a very selfish perspective, not only helping the patients, I feel much better about the day that I had, about going home and seeing my wife or my kids or my dog. And so even from a selfish perspective, I think these things can be very, very helpful for us personally.
Yeah, Howard, I really relate to that, and I applaud you for getting to a similar uh, state of mind. I often put in my clinic notes that their dog died, and 6 months later when I'm walking in or for their follow-up visit, I asked them how things are going following the passing of the dog, following that trip to someplace special, following that new relationship that they shared with me. I don't remember it, but they think I do. Did I remember it? It's in my note, and I know their PCP is scratching his or her head. Why the hell he did that find its way in the note? Which it won't with AI, because it'll be considered irrelevant. But boy, does that make a connection, and does that make the rest of the conversation far, far more productive.
Any other questions or comments? I know there's a lot. I'm sure people have a lot to think about. It was really a stimulating grand rounds. One question.
Can I ask
Oh
you a
yeah,
question?
go ahead, Dr. G. Albert.
Yeah, this is Albert. I had a question for Sean, actually. Sean, you said that you had a challenging day of call or something, and then you wrote one of your articles on your way home. How did you do that? Was that something you typed on your iPhone as you were, because I think, the journaling piece is real. And I was going to ask you, I guess, two questions. First, how did you do that? And then B, do you find that writing or journaling in an electronic sense is the same as writing like with pen to paper?
Yeah, thanks for the question. I do a lot of my writing sort of in, I don't want to say like the darkest moments because I think that's a little extreme, but I do find myself very inspired after, difficult patient encounters, a challenging call shift, difficult conversation. In this particular instance, what I typically do is I'll record myself on my phone just talking out loud on the walk home. Big picture ideas, large brushstrokes, and then with the idea that I'll go home and fill in the details later on my computer. So that's what I did in this case. I ended up doing that a decent amount of times. Um, I My experience with writing has always been on the computer. I don't really enjoy the process of putting physical pen to paper because my handwriting is terrible and it's hard to read it, and then I have to go back and transcribe it later. But I do enjoy the process of typing things out and reflecting. I think that's made me a more compassionate person, um, and it has certainly affected the way that I approach encounters in the future, especially if faced in a similar situation.
Shot.
That's good to know. Yeah, thanks
Yeah,
for
I
that.
scribble things on napkins. I've got enormous numbers of scraps of napkins around with just the beginning of a thought, and look forward to getting back to them. I do see in the chat, Doug Hannell has a very, very important observation to make. It's not what you look. It's not what you look at that matters. It's what you see. Um, Absolutely correct. There's a corollary, though, and that is it's not what you say to the patient, it's what that patient hears you say. And there's so often a discrepancy. The humanities offer us a more expansive and, I think, helpful language for our conversations rather than our technical jargon. but you still need to understand it's what they heard you say, not what you thought you told them, and you have to keep that in mind. Just want to underscore that. Very good comment, Doug. Thank you.
Well, thank you, Dr. Friedlander and Dr. Pirkle. That was really wonderful. A nice way to wrap up our 2024 series of Grand Rounds. I know everybody has to get to work, so I hope everybody has a great day, and I look forward to seeing you all Saturday evening. And Dr. Friedlander, happy holidays, and thank you again.
Thank you. Wish I could join you. Sounds great.
We'll have to figure that out for a future date.
Absolutely.
Okay.